Good afternoon, dear doctors, and welcome to the second half of our contraception session. Welcome to the second edition of Oscar Congress, Organon Scientific Congress across the region. My name is Walid Rahal. I am the brand lead for women health business for Organon, managing fertility and contraception portfolio. I am very thrilled to introduce our moderator for the next session, Dr. Mohammed Ferghali. Dr. Mohammed Ferghali is Associate Professor of OB-GYN from Ain Shams University in Egypt. He is also consultant of OB-GYN Maternity Sabah Hospital in Kuwait. He is editorial board member of BMC Women's Health and associate editor of Frontiers Reproductive Health. So, Dr. Ferghali, please, the floor is yours.
Thank you, Walid. Good evening, everyone. First, I want to thank Organon for organizing this marvelous scientific event. This is our session 4, and our speaker today is Dr. Fadi Mirza. Dr. Fadi is a consultant of obstetric and gynecology and consultant of fetal and maternal medicine in Latifa Women and Children Hospital in Dubai, and he is the director of the department. Dr. Fadi received his medical degree from the American University of Beirut in Lebanon. He completed his 4-year residency in Obs and Gynae at Tufts University in Boston. Dr. Fadi is a fellow of the American College of Obstetricians and Gynecologists. Dr. Fadi did a fellowship in maternal and fetal medicine at Vagelos College of Physicians and Surgeons, Columbia University in New York, where he was a part of the faculty and presented countless scientific abstracts along with numerous published peer-reviewed articles. Dr. Mirza is adjunct professor in Columbia University College of Physicians and Surgeons. Dr. Fadi has extensive experience in maternal fetal medicine, especially high-risk pregnancy and morphological ultrasound. He is the recipient of many awards, including the prestigious Award of Research Excellence of the Society for Maternal Fetal Medicine in USA. Dr. Fadi is a clinical professor in Mohammed bin Rashid University College of Medicine, and he is the president of Emirates Fetal Medicine Society. Dr. Fadi will talk today about the role of LARCs in contraception, the longer-acting reversible contraception. Thank you too much, Dr. Fadi, to be with us today, and the floor is yours.
Thank you very much, Dr. Muhammad, a dear friend and colleague, for the kind invitation. Thank you very much, Walid, and the entire Organon team for their kind invitation. It's a great pleasure to be with you today. And as you see, the topic of my presentation is going to be the role of LARCs in contraception. This is clearly a topic that's very dear to our hearts, very basic. It's something that I think many of you among us delivered this lecture to students, to the residents, to fellows. So what I'm going to do is really just a refresher of this topic. It's been a while since many of us have, revisited this day-to-day topic, and at the same time tackle few points that are of clinical relevance. For the sake of our French-speaking colleagues, there will be translation, as I was informed, and I'll try to go as slow as possible to allow for prompt translation. So I'd like to start with this nice, elegant schematic, which really looks at the various menu that includes a long list of contraceptive options. And as you see, the top part represents the most effective ones, including implants and IUDs, as well as the irreversible ones, which are vasectomy and tubal occlusion. Just below them, we have a wide variety of moderate, let's say, efficacious products, including the injectables, the pills, patch, etc. And then, of course, we have the least effective towards the bottom, which include withdrawal, condoms, diaphragm, etc. This is a very nice way to also look at the myriad of options that we have when it comes to contraception in the office, as well as in the hospital. You see, this is a nice schematic that looks at the different methods as a function of typical use, perfect use, as well as continuation. And these are the clinically pertinent variables when it comes to our patients. We want to know when they typically use it, how often do they experience pregnancy? In other words, the method fails. What is this number with perfect use, which is, when we expect the method to work perfectly well? And finally, the continuation, because I do care, even if it works very well, but the patient doesn't like it, obviously, I'm failing. I think you agree with me that the lower part of the table here has more appealing numbers, particularly when it comes to perfect use and continuation rate. But I think you also agree with me that when we want to look at the typical use as well as percentage of continuation, the last four are really what we're looking for. And these interestingly include the two LARCs, long-acting reversible contraceptives, namely the IUD and the Implanon, as well as the two well-known irreversible methods, which are female sterilization and male sterilization. If I want to focus our attention today on the reversible ones, because obviously the irreversible is something that is specific to specific people, it doesn't apply to everyone, then we are left with the two methods, IUD and the implant. And indeed, the American College has dedicated a practice bulletin to long-acting reversible contraception, LARC, stating that IUD, or intrauterine devices, and contraceptive implants, also called LARC, are the most effective reversible contraceptive methods. And by going back to the table that we looked at together, this makes total sense. The major advantage of LARC really, compared to other reversible contraceptive methods such as the condom or the pill or the patch, is that they do not require ongoing effort on the part of the patient for long-term and effective use. And this is why the typical use as well as the perfect use are pretty much the same, because we're not relying on the patient. And finally, a point that's very important to our patients, after the device is removed, ACOG really reassures us, just like all professional societies, that the return of fertility is rapid. This is a nice publication back in 2015 that is called the CHOICE Project. The CHOICE Project is really about giving the patient the choice. So this was an observational cohort study that provided each participant with a reversible method at no cost. Patient got to choose, and they were eligible if they met the following criteria. They were 14 to 45, they lived in St. Louis in the US, they were English or Spanish speaking, they were interested in reversible contraception, were sexually active, did not desire pregnancy in the next year, so in other words, long-term desire, and were not using any contraceptive. They were all they were all counseled in a standardized manner by trained counselors who really presented the methods from the most to the least effective, so pretty much using the table that we looked at. Then they received their contraceptive method of their choice at no cost. So whichever method the patient wanted, she got it. And those patients were interviewed at 3 and 6 months, and then every 6 months for the duration of the study. The data collected was quite vast, but primarily focusing on satisfaction, side effects, sexual behaviors, change in reproductive plans, and unintended pregnancy. Interestingly, when you look at the results of the CHOICE project, you could see that 75% of participants actually chose a LARC method, which is very important to us when we counsel our patients or when we discuss our patients. Patients, when empowered, financially, psychologically, well-informed, well-counseled, they're probably going to opt for a LARC method in the vast majority of times. In fact, when they looked at the patients who were 25 years or older, the uptake of LARCs was even higher, reaching about 80%. About continuation rates, the continuation rates were significantly higher with the LARC methods compared to the non-LARC. So you see towards the top, the continuation rate at 12 months for the LARC was about 87% compared to 57, and at 24 months was 77 compared to 41%. And you can see the breakdown of the various methods under. How about the failure rate? Does it really correspond to what I just presented when we looked together at the table? Yes. When we looked at the LARC methods, you could see here that the failure rate at year 1, year 2, and year 3 was significantly lower compared to the non-LARC methods. We're talking about 0.3%, 0.6%, and 0.9%. And this is why we probably would understand why those patients are electing to proceed with these methods. So a couple of words on IUDs, then a couple of words on implants before we conclude our talk. So when it comes to intrauterine devices, they've been around since the beginning of life. We've had them appear back in historic reports. They come in various shapes and forms. Unfortunately, the more contemporary IUDs look less scary. They look more appealing to us as clinicians as well as to our patients. IUDs are indeed the most commonly used method of reversible contraception worldwide. They're used by about 1/4 of female contraceptive users with a wide range depending on the country. IUDs have gained popularity due to their high efficacy and safety, as well as ease of use and low cost. They offer a non-surgical option that is as effective as surgical permanent contraceptive. So often the patient is given the choice. Do you want a reversible or an irreversible? And she's going to ask us, well, are they equally effective? And yes, for the most part, they are. So it's no surprise that many times the patient would elect to pursue a LARC, especially if she is unsure of her future childbearing plans. When it comes to IUDs, there are two available types. We are all familiar with those, the hormonal and the non-hormonal. Non-hormonal being the good old copper IUD, which contains copper, and it's approved for the longest duration, which is 10 years. As for the levonorgestrel, or the hormone-containing IUDs, these are available in a number of brands, namely the Mirena, which is approved for 8 years, the Liletta, approved for 6 years, the Kyleena, for 5 years, and the Skyla, approved for 3 years. And the nice thing about the different kinds of IUDs is that they can offer different options to different patients, depending on the duration of the contraception that they are interested in. And I think in this part of the world, Mirena is the well-known one in our clinical practices. This is a nice schematic that looks at the various IUDs, comparing the copper IUD to two forms of levonorgestrel, including the Mirena. You see here that the duration of therapeutic effect is highest for copper. So if a patient asks us, doctor, we want the longest, we want to forget about contraception, the copper one is probably the best option. And you can see here that the pregnancy rates are very comparable to what we discussed earlier. How does the IUD work? This is a nice table that really looks at the way that the IUD works, so method of action. We all know it's changes in cervical mucus, it's the chronic inflammatory changes in the endometrium, it's the atrophy in the endometrium, and at times direct oviductal effects. Which one? The patient is going to look you in the eyes and say, doctor, is it the copper or is it the hormonal? And here we have to go over a checklist, a basic checklist. What's the patient's preference? Does she care about having a period, quote unquote, or having cyclic bleeding? Does she prefer lighter periods or even amenorrhea? Is she tolerant of unscheduled, unpredictable bleeding? Does she want to avoid hormones? I'm sure you all agree with me. We have those patients who look at you and say, like, doctor, no hormones for me. Of course, take some counseling, but you have a number of patients that do not desire hormonal therapy, or we don't want them to take hormones, as we're going to see. Presence of heavy menstrual bleeding, presence of dysmenorrhea. These are all factors that we should take into account when we want to give the patient the choice. Reasons for patients or us to choose copper IUD: if we want to avoid exogenous hormones, whether it's a patient choice or our choice, for example, in patients with history of breast cancer, where really you don't want to take any chance. Continuation of pre-IUD bleeding pattern. We know that the copper IUD does not lead to amenorrhea, does not cause annulation, so patients are more likely going to have cyclic bleeding. And the desire, as I mentioned, for the longest term contraception, obviously the 10 years comes with the copper IUD. How about the levonorgestrel IUD? We know that it leads to a reduction in menstrual bleeding and anemia, so it's a good option for patients with heavy menstrual bleeding. It can even lead to amenorrhea in a number of patients, which would be appealing to us in a number of clinical scenarios. A reduction in dysmenorrhea, so that's an indication. And finally, treatment of endometriosis related to pelvic pain, and even treatment of endometrial hyperplasia. We often get asked in the clinical setting, doctor, is there an increased risk of PID? Earlier studies have reported that PID. However, these studies were flawed, and we now know that there are actually no increased risk of PID, although we have to acknowledge that the initial insertion is associated with that slight increase while during insertion. This is why some have advocated for the use of antibiotics, but later on we know that there is really no increase in PID, and the same applies to HPV. Ectopic pregnancy is also something we often talk to our residents and our students about. The absolute risk of pregnancy with an IUD remains very, very low, but we do have to counsel the patients that in the event of pregnancy on the IUD, there is an increased risk of ectopic, and this is an important take-home message. Infertility, no evidence of increased risk of infertility among IUD users. Let's switch gears now and talk about the second LARC, namely etonorgestrel implant or Implanon. It's a progestogen-only implant that's preloaded in a disposable, sterile, single-use applicator. It is placed subdermally, and it's a long-acting hormonal contraceptive, effective for up to 3 years. I've personally used it back in my days in the US for many, many years, and it was among the most popular alongside the IUD. Implanon was the first generation, and then Implanon next was the newer version, and trials on both have been very popular in a high number of countries, 17 for Implanon, and the newer version was studied in 6 countries, and we know it's FDA approved just like the IUDs. The implant is about 4 centimeters long, and it works by inhibiting ovulation as well as changing the viscosity of the cervical mucus. When it comes to its effect on ovulation, the first thing that the patient would ask about, or some colleagues would ask about, is, okay, doctor, you just mentioned that it inhibits ovulation. Will the estradiol concentrations drop with the placement of the implant or Implanon? The answer is no. This has actually been looked at back in 2000 in this study that looked at the estradiol concentrations, and we could see that they remained above the level seen in the early 2 follicular phase. Another question that we often get asked, any effect on the bone? Well, in the same study, the bone density remained unaltered over 2 years with no detectable difference between the 2 groups, the copper IUD as well as the implant. And why did they choose the copper IUD? Because it's an inert method. When it comes to efficacy, most of the trials report a cumulative effectiveness rate of about 99%. A couple of important clinically relevant points relate to actually the weight. So we often get asked, doctor, in your experience, does the weight affect the efficacy of the implant? Well, yes, we believe it does. We cannot exclude that the contraceptive effect in these women, we're talking about obesity, we're talking about morbid obesity here, we cannot exclude that it does get altered. So many of us, and this is an expert opinion only, would err on the side of replacing the implant earlier. And another clinically relevant point that we often get asked about is, will the same medications that affect the efficacy of oral contraceptives also reduce the efficacy of the implant? Probably, yes. Again, it's an expert opinion, and caution need to be exercised with some of these medications, especially the psychiatric ones. Bleeding pattern. We talked about bleeding pattern with IUDs. Is there a change in the bleeding pattern with the implant? Well, yes, women are more likely to have changes in their bleeding pattern. These may be related to the bleeding frequency or intensity or duration. And an important take-home message here is that the bleeding pattern that's experienced during the first 3 months is pretty much predictive of future bleeding pattern for many women. So if a woman tells you, you know what, doc, my first 3 months on the implant were horrible, probably it's not for her. But if a patient does pretty much well during the first 3 months, we can reassure her that she's probably going to be fine for the duration of the treatment. When it comes to the bleeding pattern, it's important to note that we have a wide spectrum, but 1 of 5 women will report amenorrhea. And on the other hand, 1 in 5 would report frequent and or prolonged bleeding. How do we overcome patient dissatisfaction? Counseling, counseling, counseling. It's very important to set the expectations of the patients straight from the beginning. When it comes to data on that, there's a very elegant study that combined data from 11 clinical trials with nearly 1,000 patients. It was an open label design. They looked at the frequency of bleeding, spotting, and bleeding free over a duration of 90 days. And in this study by Mansour et al., the numbers were as follows. The mean bleeding/spotting days was about 17 per 90 days, and the number of episodes was about 2. So this is something to kind of help us counsel the patients well regarding the first 90 days. Safety and efficacy, I know it's a busy slide, but this is another study by Darny et al. That really looked at the safety and efficacy, as I mentioned, from those 11 clinical trials. The most important point is something that I just presented, which is that the implant is efficacious and a safe method, and all what it takes really is counseling and counseling and counseling. The numbers are in favor of the implant. It's just about making sure we set the expectations straight. Why? Because if we do so, the rate of discontinuation is probably going to be improved. It's already a good number. This is the discontinuation rate, year 1, year 2, and year 3. And as you see, that if the patient does well with the implant, the chances of discontinuation by year 2 or by 3 is quite low, especially by year 3. So really, the biggest challenge is overcoming year 1. How about us? We know patients like it. We know data is in favor. How about us as physicians? Well, this was looked at by Mansour et al. In this open label study, 23 investigators, experienced and inexperienced with the implant, performed the procedure. And the results when the investigators were surveyed was that they were satisfied with the first insertion onward. All were satisfied or very satisfied after 12 insertions. So definitely there's a learning curve that we need to acknowledge, but the satisfaction was quite high. Only 2% of insertion were considered difficult when it comes to skin puncturing and or sliding of the needle subdermally. So only 2%. So in conclusion, yes, the satisfaction by physicians was quite high as well. When should we avoid the implant insertion? The typical things that we're all familiar with, things that make sense: known or suspected pregnancy, active venous thromboembolic disorders, known or suspected malignancy, when it comes to sex steroid sensitive malignancies, presence or history of liver tumors being benign or malignant, hepatic disease, undiagnosed vaginal bleeding, and finally hypersensitivity to any of the substances included. I'm going to end my talk with a few points that are derived from ACOG's recommendations and things that are really important to us as clinicians. Nulliparity, it's something that we talk about often and we get asked by patients often. Doctor, I'm a nulliparous lady. Can an IUD or an implant be used in my case? The ACOG, among other professional societies, clearly state that IUDs and contraceptive implants should be offered routinely to nulliparous women as safe and effective options. And the US MEC assigns category 1, in other words, no restriction to the use of the implant by nulliparous women and adolescents, which are a vulnerable group that we should really keep in the back of our head. As for the IUDs in the same group, it's also a category 2. In other words, advantages outweigh the risks. Timing of insertion, I know many of us have historically erred on the side of placing the IUD right after the period, but when it comes to the recommendations, IUD and implant can be used at any time during the menstrual cycle as long as pregnancy be reasonably excluded. Effect on menstrual cycles, what does ACOG state here? Again, the same point that I mentioned, counseling the patients about what to expect with each method. Antibiotic prophylaxis, when it comes to IUD insertion, we talked about the point of PID. Routine antibiotic prophylaxis is not recommended before IUD insertion. It has not been shown to decrease the likelihood of PID or the IUD removal rates. Another way to look at the eligibility of patients to LARCs comes from the WHO guidelines. The WHO include 4 categories. Category 1 refers to or includes a condition for which there is no restriction for the use of a contraceptive method. In other words, sure, go for it. Category 2 would refer to a condition in which the advantages of using the method outweigh the theoretical or proven risk. Category 3 would include conditions in which the theoretical or proven risks outweigh the advantages of the method. And finally, category 4 refers to conditions that represent an unacceptable risk if the method is used. So clearly, we're better off with categories 1 and 2. We should avoid category 3 and we should avoid category 4 at all costs. So what do we do when it comes to venous thromboembolism and the overview of the various methods? So as you see, when it comes to LARCs, history of VTEs does not preclude the use of LARCs, particularly the copper IUD, but also the implants and the levonorgestrel. When it comes to acute VTE, you probably want to avoid it, especially if the VTE occurred acutely at or on the method. When it comes to chronic, we're okay. So bottom line here, history of VTE or chronic VTE, you're good to go with the various LARCs. Cardiovascular disease, stroke, no problem with LARCs. You could look here and see that OCPs and injectables are a big no when it comes to strokes. Same thing applies to ischemic heart disease. Yes, we can use LARCs. And finally, having different risk or multiple risk factors for cardiovascular disease, you want to avoid the combined hormonal contraceptives and injectables. But yes, you are welcome to use the LARC. Other high-risk conditions, such as hypertension. For controlled hypertension, you could see that category 1 for all LARCs. Uncontrolled hypertension, 1 to 2, so we're still okay. Certainly avoiding the other options. When it comes to obesity, no problem with the use of the LARCs, but again, we may have to make some modifications as I touched up upon earlier, and diabetes, no problem, category 1 to 2. Postpartum, we often get asked, clearly the OCPs and the progestin-only injectables are a big no here. But when it comes to the LARCs, all the LARCs are okay to use starting 4 weeks onwards. Smoking, I think this is something that we often talk about, or we've learned since our early medical school days. OCPs above 35, no, we cannot use with smokers. But when you look at LARCs, regardless of age, smoking is not a contraindication to any of the LARCs. Another important point, migraines or headaches in general, you could see that both non-migraines as well as migraine headaches are not a contraindication to the use of all LARCs. I will end my talk with a reminder of the menu of contraceptives, focusing our attention on the various LARCs. It's easy to tell, and I hope I demonstrated to you that it appears to be the most efficacious and the most satisfying to patients and the safest. And remember one thing, there's no shoe that fits all. So the more options available to us, the more options we can offer to our patients. And this way we can ensure patient satisfaction, patient safety, and achieving of our goal of contraception, which often saves lives, as you all know. And thank you very much for your attention.
Thank you, Dr. Fadi, for this valid, clear information about the LARCs and sharing with us studies showing the evidence of the use of implants. I will start.
Thank you.
Welcome, Dr. Fadi. I will start the questions by my question. If I counsel a patient about the LARCs and she asked me if the Kaba ICD can do the job alone, why to use Mirena?
Very good question. So I think, Dr. Muhammad, there's no shoe that fits all. I think it's all about counseling. That patient might be somebody who has heavy menstrual bleeding to start with. So Mirena might be a better option for her. She may suffer from debilitating dysmenorrhea, so Mirena might be better for her. So I think it's all about the patient characteristics, patient counseling, and finding which one is better. If there is really no specific indication for one or over the other, then obviously the copper IUD would offer the longer term one and would be appealing to patients who are done pretty much with childbearing and want something that would stay for 10 plus years.
Okay, Dr. Fadi. The other question regarding the obesity. You said that in obese women, we must place the implants before series. What do you think? At what time and what we can do to know when to replace the implant?
It's a very good question. I don't think any of us know the answer. It's an expert opinion to say that it's a good idea to remove it earlier. I think if we're dealing with morbid obesity, it's reasonable to remove at 2 years rather than 3 years. But again, anyone might come out and disagree and say, oh, there's no studies, you can continue to 3, and it's a valid point. But if you want to be conservative, I think it's reasonable to stop at 2 years and replace it at that time. And this way, you can just try to avoid that, at least theoretical risk.
Yes. Thank you, Dr. Fadi. Another questions about the contraception in Emirates. She said that insurance not cover all the contraception, even consultation, and all are so high prices. Also, we have over 200 nationalities. Still, contraception is a problem.
It's true.
In Emirates, what you experience?
Yeah, it's true, Dr. Muhammad. So, I think contraception is regarded as a luxury, and if you look at insurers and insurance company or insurance plans, will actually shy away from preventive methods. And yes, today we are dealing with companies that would not even cover a pap smear because it's considered preventive. It's considered it's not necessary. So by the same token, I'm not surprised that many insurers would not cover contraception in general. And yes, they are expensive. I'm going to seize that opportunity to bring up an important point. When we look at the price of LARCs compared to non-LARCs, the price per unit is higher, but we have a number of cost-effective studies that I removed for the sake of time from the presentation that really look at the cost-effectiveness long-term. And actually, with LARCs, you are saving money. So instead of, just going to use an example, instead of paying 3 years worth of OCPs, you're paying the price of one implant, for example. The overall cost is going to be significantly lower. And I think this is something that we all relate to, and it has been supported by data.
Yes, Dr. Fadi. I am always happy to hear you and to be with you in meetings. Thank you so much for your presence today in our session. And further question can be posted in the network lounge, and Dr. Fadi is happy to answer your question if you have any. Thank you.
Thank you very much, Dr. Muhammad. Thank you very much, everyone.
1 minute and we'll move to the next session, inshallah.
One.
Hi, everyone. Welcome to the session 5 of the version 2 of Organon Scientific Congress across the region. Our speaker in this session will be Professor Gamal Mustafa. Professor Gamal is a consultant of obstetric and gynecology in Alia International Hospital, Kuwait, and he is the head of the department. Dr. Gamal received his medical degree from Ain Shams University, Cairo, Egypt in 1995, and he is a professor of obstetric and gynecology in Ain Shams University since 2012. Dr. Gamal was licensed as consultant for obstetric and gynecology in Egypt, in Kuwait, in Sudan, and in KSA. Dr. Gamal had experience in work of the Gulf region for more than 20 years, and Dr. Gamal had experience in setting up and management of hospital and IVF centers. Dr. Gamal will talk to us today about the post-luc insertion patient counseling. Thank you too much, Professor Gamal, for being with us today, and the floor is yours.
Thank you, Professor Muhammad. It's my pleasure to join you in this short talk. Actually, I will talk about the post-luc insertion counseling, and I actually designed my talk to be suitable not only for gynecologists or professionals in contraception, but it will be suitable also for any general practitioner and any healthcare provider. Let us talk a short about what is counseling. Counseling is the provision of professional assistance and guidance in resolving personal or psychological problems. Counseling is a collaborative effort between the counselor and the client. It is a strategy to empower women who don't desire pregnancy.
Dr. Gamal, please, can you share your screen?
I share it already.
You don't see your screen.
Sorry. Is it okay now?
I can see it.
Okay, I will start again.
Yes, please, Dr. Gamal.
Yes, okay. So when we talk about counseling, it is the provision of professional assistance and guidance in resolving personal or psychological problems. Counseling is a collaborative effort between the counselor and the client. It is a strategy to empower the women who don't desire pregnancy to choose a method of birth control that she can use correctly and consistently over time, thereby reducing her individual risk of unintended pregnancy. The long-acting reversible contraception, as Dr. Fadi explained, is mostly the intrauterine contraceptive device and the implant. Both are highly effective in preventing pregnancy, more than 99%, and they last for several years and are easy to use, and both methods are reversible. We will concentrate today about the post-implant insertion counseling, as this is an important issue because the IUD is longer used before the implant, and nearly everyone knows how to counsel about it. The after-LARC insertion care. First, after insertion, the clinician will ask the lady to feel the device under her arm skin. She should check his this periodically over the 3 years. If she can't feel the device at any time, she should seek medical advice. Advise the user of the implant to keep the area of insertion clean and dry for 5 days. Don't push the device or play with it after the insertion. User may have a small scar at the insertion site. So this is the immediate care after the implant insertion. There is a follow-up documents. The user will be given a card with the dates of insertion and must retain this to ensure that the implant removed at the appropriate time. If user like the implant removed earlier, then she must book with a clinician to discuss. If user lost the card, she can contact the medical center as she will not be routinely reminded by the expiry date of her implant. When does it start working? There is one of the questions usually asked by our clients. The implant is immediately effective if inserted during the first 5 days of a menstrual cycle, which starts with the first day of the bleeding. If the implant is inserted after 7 days, the implant is effective after 7 days if it is inserted at any other time in the menstrual cycle. Other contraceptive measures such as condoms or abstinence should be used for these 7 days. One important thing, the implant does not protect against sexually transmitted infections or bloodborne viruses. Practice safer sex. Condoms reduce the risk of sexually transmitted infection and the bloodborne viruses. What are the benefits of the implant? This is one of the important points to be explained to the client. It is highly effective. It lasts a long time. It is reversible and the return to fertility is rapid. It does not need the user to remember to take a pill every day. It is a cost-effective method of contraception. It may reduce painful periods, premenstrual syndrome, and acne in some users. Can medication impact the effectiveness of the implant? We have also to get our clients that the implant is affected by enzyme-inducing drugs, such as barbiturates, carbamazepine, phenytoins, and rifampicin. The patient medication history should be checked prior to being commenced of the implant, and the user should also be told to make other clinicians aware of their implant before starting a new medication. Call your doctor at once if you have. This is an important issue. The client must be instructed to call her doctor if she feels warmth, redness, swelling, or oozing where the implant was inserted, severe pain or cramping in your pelvic area, maybe only on one side, signs of a stroke like sudden numbness or weakness, especially on one side of the body, sudden severe headache, slurred speech, problems with vision or balance, signs of a blood clot, sudden vision loss, stabbing chest pain, feeling short of breath, coughing up blood, pain or warmth in one or both legs. And also call your doctor if you have heart attack symptoms like chest pain or pressure, pain spreading to your jaw, shoulder, nausea, sweating, increased blood pressure, severe headache, blurred vision, pounding of your neck or ears, swelling in your hands, ankles or feet, jaundice, yellowing of the skin or eyes, a breast lump, symptoms of depression, sleep problems, weakness, tired feeling, mood changes. Let us explain also to the client what are the side effects. Many users have no side effects. Bleeding patterns are likely to change. Periods may be at the normal times, but they may be lighter or less painful. Periods may stop altogether, and occasional bleeding may happen without a regular period. Increased bleeding happens sometimes. This can include bleeding more often, heavier bleeding, or a combination of both. Side effects also to be explained, and some users may experience the following problems. Acne may develop, improve, or get worse. Weight gain can occur over the time. Headaches, breast pain, and mood changes can occur. Bruising and mild soreness at the site of the insertion or removal. A small scar remains at insertion site. Occasionally, the implant can be difficult to feel or remove, and we may need an ultrasound or X-ray to check its position in the client's eye. Many also, she will ask, how do I stop using it? To stop using the implant, it needs to be removed by a doctor or a nurse. This involves an injection of local anesthetic and a small cut to the skin to find the tip of the implant and remove it. It usually takes from 5 to 10 minutes. When will I be fertile again? This is one of the most important questions about the implant. Progesterone levels are not detectable within a week of the removal of the implant. Most people return to their normal menstrual cycle and fertility within a month of removing the implant. If user don't want to be pregnant, she needs to use other contraception method as soon as implant is removed. Let us go now to an important issue in the counseling, the myths and facts about the implant. We're facing this every day. The myth, pregnant while using an implant. Some women who seek family planning believe that implants will interrupt an existing pregnancy. The fact, a fetus will not be harmed by insertion of implant as it works primarily by thickening of the cervical mucus, which blocks sperm from meeting an egg and by preventing ovulation. Implants don't interrupt pregnancy. Good evidence show that implants will not affect the pregnancy or harm the fetus if a woman is already pregnant when the implants are inserted or becomes pregnant while using the implant. Myth. Removing an implant is a painful surgery. Some women have misconceptions about the removal of the implant. The fact, infection at the site, infection at the insertion site can occur, but is uncommon. And when infection occurs, it is usually within the first 2 months after insertion. No stitches, no noticeable scar, and it can be removed at any time. The woman remains fully awake during the procedure of removal. A woman can have her implant removed at any time, similar to insertion using local anesthesia, and does not require stitches in about 3 to 5 minutes. Difficulties with removal are rare if the implant were properly inserted and the provider is skilled. Myth, health risks and side effects. Some women have misconceptions about implants causing illness or problems such as cancer, blindness, or birth defects. The fact, in addition to changes in menstrual bleeding, the most common side effects of implant are headaches, abdominal pain, and breast tenderness. These side effects are not an indication of illness and usually lessen or go away with the first year of use. Studies have not shown increased risk of cancer or blindness or birth defects with the use of the implants. They have been shown to greatly reduce the risk of ectopic pregnancy and protect against symptomatic pelvic inflammatory disease. Implants may also help protect against iron deficiency. The myth, migration of the implant. This is one also of the common myths about the implant. Some women believe that implants can travel from the insertion site to other parts of the body. The fact, implants cannot travel to other parts of the body. They remain where they are inserted, they are removed. In rare cases, a rod may start to come out of the skin, usually during the first 4 months since insertion. This typically happens because the implant were not inserted well or because an infection at the insertion site. If expulsion occurs, the woman should return to the clinic as soon as possible and use a backup family planning method. In the meanwhile, provider can replace the rod easily. Infertility and the ectopic pregnancy. Some women believe that using implants will cause infertility, delay the return of fertility after the implant are removed, or cause ectopic pregnancy. The fact, implant does not affect fertility and reduces the risk of ectopic. Implants stop working once they are removed, and their hormones don't remain in the woman's body. Implant use don't affect the woman's ability to become pregnant. Also, fertility decreases with a woman's age. One major study found that women who have had their implants removed can become pregnant as quickly as women who have stopped using a non-hormonal methods. Myth, infertility and ectopic pregnancy to continue. Implants substantially reduce the risk of ectopic. In the United States, the rate of ectopic pregnancy among women who are not using a contraceptive method is 650 ectopic per 100,000 women a year. The rate of ectopic pregnancy among the women using implants in 6 ectopic pregnancies per 100,000 women per year. Even in the very rare case when implants fail and the pregnancy occur, the great majority of these pregnancies are not ectopic. Only 10 to 17 of every 100 pregnancies due to failure of implant are ectopic. The myth, who can use the method? This is an important myth. Some women believe that implants should not be used by women who are young or who have not had children yet. The fact, nearly all women can use implants safely and effectively. Implants are suitable for women of any age, regardless of whether they have had children or not. Fertility returns as soon as implants are removed. Breastfeeding women can use the implants immediate. Postpartum insertion is increasingly growing. This is changed than before. There's some saying before that it should be inserted after 6 weeks of delivery, but actually since about 4 to 5 years, this belief is changed. Implants may not be suitable for women who require a family planning method without hormones. Myth, the menstrual bleeding. Some women incorrectly believe that using implants will cause harmful changes to menstrual bleeding. The fact, changes may occur, but generally they are not harmful, and some women don't experience any change. Typically, changes in the bleeding pattern are more dramatic during the first year of use and either lessen or stop after the first year. Prolonged or heavy bleeding was lasting over 8 days or generating twice as much as blood as normal due to implants generally is not harmful. Menstruation may also cease after 1 or 2 years of implant use, which is not harmful either. Blood will not build up inside the woman. The myth, the sexual pleasure. Some women believe that implants will reduce a woman's libido or affect a couple's sexual life in some way. The fact, no evidence to suggest that implants can reduce a woman's libido. Some women using implants report negative changes in mood and sex drive, while some report improved mood and sex drive. Such changes could be caused by many other factors, so it is difficult to attribute them to the implant use. There is also must be a support after the insertion of the implant. Another important rule for healthcare provider is to be available by phone or clinic visit after insertion to assist the woman with concerns or problems. Providing counseling and reassurance has been shown to increase user acceptance of side effects and to decrease the discontinuation rates. Some clinicians suggest a scheduled for visit 1 month after the insertion to inspect the insertion site and check for any user concerns. Thank you so much.
Thank you, Professor Gamal, for this nice presentation and this valid information. My first question will be about the counseling is very important, but did you think that counseling about side effects and health risk to be post-insertion or before insertion?
I think to be primarily pre-insertion, and we have to emphasize some of them after the insertion to reassure the lady that we are not only doing the counseling to encourage her or to deceive her. Yani after the insertion, usually the woman khalas is inserted.
We repeat what I said before.
Yes, we have to repeat that there is some side effects, is not harmful, some myths and facts, because maybe the woman usually didn't say every concern before the insertion. Many women after the 1 month, usually I prefer the 1 month visit post-insertion, because now when we start the implants, there was no internet and the Google and the TikTok and the Facebook. But now the lady will insert and go search about everything and come after that to ask many questions. So I think counseling is a continuous subject before, during, after any of the contraceptive measures.
Yes. Did you ask your patient to go to the net and search and know about the side effects and the health risk and come to you to either say the facts or to tell her what is the fact about this, or you prefer that you are the first one who counsels the patient?
Usually the patient come to you already searched. Yani this is very, very rarely that one patient will come to you without this. She usually search the net, ask her friends, and ask a previous user usually about, or she will encourage it by a previous user. Yani usually the previous user is a good counselor if he has no problem to the lady. But usually I will tell the patient, you can read anything, but read it as a patient, not as a professional, because there is different information for the professional, not like that. This is exactly like the pamphlet inside every medication. If the patient read this pamphlet, he will never take even Panadol.
Yes. We have a question from Heba. She's a specialist and asking about how to overcome the breakthrough bleeding with Implanon.
Actually, we give a very long lecture about that
Yes.
a few weeks back in Abu Dhabi.
But in few steps, what is the plan and what is the workup she must do to overcome this?
The workup at first, we have to exclude any pathology. This is the most important thing. We have to be assured the lady that she have no pathology, and this is only a change of the pattern of the bleeding, as in the counseling she was being told. We have to manage after that. Of course, if you found a pathology, we have to check the CBC, check her coagulation, sound to get her assured of the thing. We have to examine the site of the implant insertion. If we are talking about ICD, also the same. We have to do the same. Ensure that the intrauterine device in place. There is no infection, no cervical erosion, no something like that. After that, if it is only from the side effect, we have to start to reassure her if the amount of the bleeding is not affecting her general condition or not affecting social life. I think the reassurance is enough for some time. Don't interfere by medication, because if we interfere by medication from the first visit, the lady is afraid that she is diseased. And this is a concept. If we give any patient, even if we give her a simple medication, non-steroidal anti-inflammatory or something like that for the bleeding, she will say that this implant causing a disease for her. So then we start by non-steroidal anti-inflammatory. We can start by medications that improve the coagulation of the blood. We can use a hormonal, not necessarily contraception, but a hormonal treatment for the bleeding. And this is usually occur within the first months, mostly the first 1 year. If the bleeding is so heavy, we have to counsel the lady. She can take the medication for a short period, not improve. She has the choice to remove her implant and switch to another contraceptive.
Yes, thank you, Dr. Gamal. We have another question from Dr. Shadi. I know that Dr. Fadi explained this in the medical eligibility criteria, but he asked about, can the patient with family history of thromboembolism use Implanon or not?
Actually, Dr. Fadi explained
this is the medical eligibility criteria.
This is the medical eligibility criteria, and we have to from my point of view, have to take a very good history for any contraceptive client. Any lady asking for contraception, we cannot concentrate on her history only. We have to take the history of the family, about the breast cancer, about kidney cancer, about the coagulation problems, about the heart disease, about the diabetes, about the hypertension, because many of our patients discovered for the first time blood problem in their health in the first contraception visit.
Yes.
We discovered her pre-diabetic, or she have a breast lump, or something like that.
Did you think that history is enough, or there are some investigation to be done for sympathy doing this, or history is enough?
I think in the Gulf area is not enough, because we have many problems with the thrombophilia, and this also reflects upon the repeated abortion and upon the familial, because of the consanguinity in marriage is more than any part of the world. No, I think we have to investigate. If we are suspecting anything, the investigation is simple, and for the general benefit of the lady, she can know, because the blood diseases, I worked in the Saudi Arabia, in the eastern region, the blood diseases, especially the sickling and the G6PD, and all of this, they are familial, and the percentage is high. No, we have to investigate.
We have to investigate.
Yes.
But our last question, this is from Professor Gamal. I think you sent it to Dr. Fadi, but I wanted to hear from you.
Yes.
About the immediate postpartum lapse.
Yes. I wanted to.
I know that you have a long experience with this.
No, I wanted to ask Dr. Fadi about it in the United Arab Emirates. If this is starting to be applied. Actually, here in Kuwait, in Egypt, of course, we practice the immediate postpartum IUD since about 20 years. Especially immediately after abortion, immediately after vaginal delivery, after placental delivery, and immediately after placental extraction in cesarean section. Actually, in Kuwait, I have now started since for 2 years. Some of the patients accepting that the implant can be inserted immediately after the delivery, especially after the cesarean section, if she is not willing to do a tubal ligation because of the social factors and the religious factor and something like that. If she needs a permanent, long-acting and reversible at the same time method, some patients inserted for them actually after the delivery the implant.
There is a question, is there a relation between the body mass index and the frequency of abnormal uterine bleeding with implanon?
Actually, as I heard from Dr. Fadi, this is a personal opinion, and I cannot say it is a study. Yes, we noticed that usually the patient, the not obese patient, has less frequent bleeding problems than the obese one. I think this is related also to the fat distribution of the hormones and the effect of the hormones like that. But this I don't know a scientific study, any evidence.
Yes. Thank you, Professor Gamal, for
Thank you so
your
much.
nice presentation and for answering the question. Further question can be posted to the network launch, and Dr. Gamal is happy to answer your questions. And we'll move to the next session, inshallah. Thank you.
Thank you so much. Thank you.
Hi everyone, welcome to our last session of version 2 of OSCAR, Organon Scientific Congress across the region. Our speaker in this session will be Dr. Farid Benapouche. Dr. Farid is consultant of obstetric and gynecology. Dr. Farid had an European diploma in endoscopy from the University of Auvergne in Clermont-Ferrand and had a diploma in endoscopy from Hamburg, Germany. Dr. Farid is the Secretary General of the Algerian Society of Endoscope and Advanced Technique in Obstetric and Gynecology. Dr. Benapouche is a highly reputed gynecologist in Algeria. He has been in private practice for many years and he's recognized as a national expert in histoscopy. Dr. Farid is also the undisputed master of the training since he has already provided several sessions for the gynecologist. Welcome, Dr. Farid, and we are happy to have you in this session. And we are looking to see your operative office histoscopy, and the floor is yours.
Okay, thank you. I will share my screen. It's an honor for me to participate at these big and great events, and I would like to thank Organon for his invitation and their commitment in the medical continuing education. So I present an innovative topic about operative office hysteroscopy. As since 1807 to 2004, Buzzini speak about light conductor as first endoscope. Now we are speaking about robotic hysteroscopy procedure. So the hysteroscopy device market is increasing because of its good outcomes in the treatment of intrauterine pathology. Before speaking about the hysteroscopy, we recognize that ultrasound became the virtual hysteroscopy. It is very helpful because it gives us measurement and accurate diagnosis to facilitate all the procedure in hysteroscopy. So we have to do a perioperative management before surgery, during surgery, and after surgery. Before surgery, we have to have lesional mapping, and so we need ultrasound, and we need saline infusion sonography to do the best diagnosis and to give the measurement to have the safe and efficiency procedure. So we have to choose in the second the good instrument for the good technique, and all these devices are available, are helpful to perform surgery in office hysteroscopy. And after the good surgery with a good technique, we have to assess and to evaluate surgery to perform another hysteroscopy 6 weeks after the first one to know if we have to do another procedure, for example. And we have 3 great societies: European Society of Gynecology and Endoscopy, Global Congress on Hysteroscopy, AGL. They formed an international group of experts in hysteroscopy, and they developed an international consensus statement for recommended terminology describing hysteroscopic procedure. And they developed to the classification onto the level or the pain relief. So for hysteroscopy, for example, we have to stop there, oral or inhalation medication with sedative effect. So there's 3 society defined so the office hysteroscopy as when the hysteroscopic procedure is performed in a medical practitioner's professional premises, where pain control up to level 3A as said, can be administered. And this slide shows the different other type of hysteroscopy. Office hysteroscopy is not the same as outpatient, ambulatory, extended recovery, and inpatient. But it depends of the healthy system. In United States, for example, the term of office and outpatient are used interchangeably and means the same thing. So office hysteroscopy is now recognized as the gold standard of see and treat all the uterine pathology. It became a most common procedure in hysteroscopy because of small of diameter, because of the excellent analgesia protocol, and because the increased convenience, cost effectiveness, especially when you compare with the patient who went in the operative room. So the question, why the office hysteroscopy? Because it is the minimal invasive surgery. There is no more minimal than this technique. And she can give us the histologic proof without anesthesia, without preoperative medication, and it is cheaper, like you see there, $62 versus $2,800. So we have to go over this type of procedure to reduce our healthy system. But as all the surgery, this is a limitation of this office hysteroscopy. The limitation depends of the surgeon, depends of the patient, especially the toxicities, and it depends of the equipment, and also depends of the pathology. We don't treat the large myoma like the little myoma, for example. We don't treat at the same level the septum, the total septum, and the little symptom. So we have to treat all pathology differently. Of course, the success of the office hysteroscopy depends of the skill and the knowledge of the gynecologist. But the gynecologist and the surgeon, he had a concern about the patient observing. He asked, the patient is observing me how to manage. And he had other concern like the reimbursement issue and to work without anesthesia. Patient also is depend the limitation in office hysteroscopy, and she wonders about awake. I will be awake. I will feel everything. I will feel pain. So she is afraid about doing a surgery awake. So we have to reassure that patient for providing good counseling before surgery and during. So we have to discuss with the patient during surgery. So in 1997, Stefano Bocconi, one of the revolution in hysteroscopy, described the vaginoscopic approach to reduce the pain of office hysteroscopy. At first, for the diagnosis only, but now we use the vaginoscopy even for operative office hysteroscopy. As you see in the video, we are crossing very slowly the cervix because it is the most important thing what we do to avoid and to reduce the pain. And when you enter in the cavity, there is no problem and the pathology is easy to recognize. As defined by Stefano Bocconi, vaginoscopy is not touch technique. So without speculum, without using tenaculum, without entering in the operative room, as defined by the consensus in the practitioners local, and we don't use any misoprostol and any medication, antibiotic, analgesic. So the tips and tricks, as said, crossing the endocervix canal is the most important time. We have to be quiet. We have to do step by step. And during this procedure, during the beginning of the procedure, we have to discuss with the patient. We have to ask them to breathe, to relax. And as defined by Stefano Bertocchi, the local vocal anesthesia, we have to discuss, and with the patient, it was an anesthesia. So it is important to work in the quiet environment with the music, for example. And when you do the procedure, we have to make small movements. We have to avoid the uterinoir. That is the moment where she can feel the pain. But all vaginoscopy techniques are not the same, are not easy. This one, as you see, I try to cross the cervix slowly. I respect all the procedure. When you arrive in the OS, here, when you have in the OS, normally we enter inside the cavity, but we have a barrier. We have a barrier here. Finally, the uterus is retroflected. Pay attention when the uterus is retroflected. You have to know that before doing surgery. And for office, we don't need to have all the equipment what we had in the habit in the operative room. Compact solution are sufficient to do this office stereoscopy, because now they are high definition with very nice light. But it is recommended to have a dedicated room with dedicated personnel to be more efficient. Do we need a stereo pump? It is not mandatory to have a stereo pump in office stereoscopy, but we have to now to manage the input or the output. We have to assess it during the surgery. So we have to stop, for example, when we do more than 60 minutes. But in office stereoscopy, it is recommended to do the small surgery when we have to perform during 60 minutes. It is better to go to the operative room. So this publication, even it is old, confirm that we have to work in the lowest intrauterine perfusion as lower as possible, and it range from 25 to 50 minutes, lower than that. But sometimes we have to increase this pressure. But you have to know when you increase this pressure, the patient can feel the pain. So no need to pump. You have to know that when the serum bag is at 1.50 meters from the ground, the intrauterine pressure is about 70 millimeters of mercury. The checklist have to be respected, and we have more instrument, mechanical instrument, scissor, tenaculum, grasp forceps. We have electrical instrument in the French 5 gauge, and the very nice innovation is this mini resectoscope with 15 Charrier, 15 French, the external sheath. So we can do the resection in office stereoscopy. Another innovation, another revolution is the appearance of the tissue removal device. And the last one, intrauterine Bugatti shaver, is the 5 French diameter, external diameter, we can perform in office hysteroscopy without going to the operative. We have to choose instruments too, new instruments. For example, hysterometer. There you see the spirotom or uterospirotom. How to do this? With the spirotom, we can do the biopsy, the deep biopsy inside the meiothelium to increase the diagnosis of adenomyosis. And the snake biopsy is very interesting because we can have a good biopsy to learn in histological in histology. And we have graphs and scissors, 7 French, more strong than 5 French in the habit. All these devices are available to do with a mechanical instrument. The mini resector, I said, is very interesting. For whom this mini resector? I show you a very interesting T-shaped uterus, and with a knife with the mini resectoscope, we cut we do the enlargement of the cavity, and we cut the lateral wall. This patient present also a neck little symptom, and we cut it at the same time. And you know, at the last, you have a very nice enlargement of the uterus. For home, also mini resectoscope, we can do also the treatment of the septum with a bipolar knife like this, and we cut from the cervix to the fundus until to arrive on the fundus near the ostium, tubal ostia. The Ismocel is another good choice for these mini resectoscope. Here we use 360-degree technique from Cubini, from Italia, and he resect the inferior edge of the Ismocel after he resect the superior wall, and he resect all the endometrium surrounding this Ismocel. And at the end, we have a very good drainage of the blood. And in this study, Gubini doesn't found any adhesion, any perforation. Even he used it for the Ismocel less than 2 centimeter residual myometrial thickness. Very nice innovation, I said. The first one was born in 2007 by TrueClear, but for our part, we use a shave from stock because it is reusable. And like you see, you enter in the cavity with a vaginoscopy technique, and you have a large polyp. Just put cause the polyp, and the polyp is removing without managing the chips. You see, the chips are aspirated at the same time, and the result is very interesting. We can do it faster without insertion and reinsertion onto the device. It is very interesting. Even for the young gynecologian, it doesn't need any expertise. It is as easy to use. We can use this device for other indication, for the polyp, for the polypoid hypertrophy. The very nice indication is the retained product of conception. Here After removing the polyp, we remove the small hypertrophia in the isthmic region. So for this intraethylene ligand shaver, we have to know the setting of for the good use, but you have to know we have to reduce the speed of the unidrive less than 1,000 revolutions per minute to remove strong tissue. It is different to remove polyp. All the energy can be used in office stereoscopy. I think we have to exclude the monopolar not only in office but in stereoscopy. We have to do the most procedure by bipolar, and we prefer mechanical energy because it decreases the rate of synergy with energy. We have no experience with the laser, but the laser can be used in this field. Ultrasound guidance. Ultrasound is very important before surgery, but as you see, it decreases the perforation of the perforation than laparoscopic guidance. So we have to use it when you perform this procedure in the severe adhesion, when in the myoma T3, when the residual myometrial thickness is insufficient, we can use ultrasound guidance. It avoids perforation. The infection is very low in stereoscopy procedure, less than 1%, and all the society doesn't recommend to prescribe antibiotic in operative nor in diagnostic procedure. Pain is the main reason for failure of stereoscopy. So we have to assess this pain by the visual analogic scale, and when you discuss with the patient during the procedure. You have to know that the pain does not depend on the location of the lesion, but it depends on the technique. I said we have to avoid, for example, the wall. When you touch the wall, the patient is painful. Of course, by vaginoscopy, the pain is less versus standard stereoscopy with spiculum and tenaculum. So, some authors prefer to prescribe tramadol and selexokib anti-inflammatory. They are effective in reducing pain in outpatient procedure. The risk factor for painful in office stereoscopy is menopause. Of course, in menopause, we have more stenosis. We have more fibrotic on those cervix. In nulliparity, also it is so difficult in nulliparous versus multiparous. So we have to do the procedure of short time. If we have to do in long time, we have to avoid this technique. Of course, stereoscopy have to have an experience before going to office stereoscopy. To place, we have more treatment. We have pharmacologic treatment, non-steroidal anti-inflammatory, prostaglandin, opioid, local anesthetic, antispasmodic, but we have also non-pharmacological treatment. We talk about uterine pressure, the lower as possible, as low as possible. The stretching, we have to fill the bladder to reduce the angle before the cervix and the uterus. The heat is a good option. Transcutaneous electrical nerve stimulation, hypnosis. I insist for the local and vocal and the quiet environment like music one. And these options are compared by the Cochrane Library, and they conclude that there was no consistent good quality evidence of clinically meaningful difference in safety or effectiveness between different states of pain relief. Sorry. Of course, otoscopy is the gold standard for to treat and to see major abnormality, but it can also see and treat minor abnormality, which change of the appearance without deformation of the normal cavity, the normal anatomy of the uterine anatomy. So, like this, in this video, you show purulent liquid, which is which have some problem. We have to enter it. This one, you have dystrophic endometrium with modification of vascularity in this endometrium, and you know all that there is more sign of endometritis, like here, strawberry aspect of endometrium. At the first, office cystoscopy was dedicated for diagnosis, but there are many publications, and there's one with 2,000 cases of office cystoscopy, conclude that well-selected case of congenital anomaly, deeply located, a larger submucous myoma, larger polyp, and severe intrauterine adhesion can be safely and faster treated outside the operating room. See, now, I think the trend will be to the office hysteroscopy. And one of the challenge of the office hysteroscopy now, last year, there is a consensus between three great societies, and they say that the curettage is dead. Even when we treat a miscarriage, we can do it in office hysteroscopy, and they conclude that the level of evidence shows the superiority of direct visualization procedure. For treating a myoma in office hysteroscopy, many publications. The first one by Stanislaw Betocki, it is Otium technique. He did the incision surround the myoma, and he did a second procedure 2 months later. Someone described the myomectomy without extraction of the myoma. He let the myoma inside the cavity, and after 2 months after, the myoma disappeared. Donc, I show you little myoma where we did it in office just to cut the connection between the myoma and the uterus. After we take it by tenaculum, you saw that we have to extract it very not quickly, very slowly. And there is another pseudocapsule resect. It is a new technique which is to respect this pseudocapsule, which is different the myometum, which is different the myoma. With glass, we go in the image plane of this myoma, and we dissect the myoma as in laparotomy, and we remove all the myoma like this. It is recommended to remove it slowly at the end. Office, the septum. What about the septum in office? The Betocki described in 2007 how to recognize the septum in office hysteroscopy. When you see in this video the whitish tissue, so you are in the septum. When there is no vessel until the border with the myometrium is reached. When you have a vessel, you have to know that you are in the myometrium, you are not in the septum. Also, in office, there has no sensitive innervation. There is no innervation in the septum. When the patient feels the pain, you have to stop the procedure. So you reached the myometrium. So there is 3 techniques to treat the septum: by cold scissor, by monopolar needle. It is there is no concern about synergia when you use monopolar in synergia, especially in synergia, in septum, because the rate of the synergia in this case less than 1 centimeter. And we can treat by mini resectoscope, for example. I show you a new case in conservative cesarean scale pregnancy treatment. In this case, you see the pregnancy, the cavity is empty, there is nothing, and this is a connection between the pregnancy is in the niche. So we go with a needle by hysteroscopy, we aspirate the pregnancy, and after we inject the methotrexate in situ inside the pregnancy. The result was very good, and the beta-IgG was negative 15 days after. Office hysteroscopy with the see and treat approach allows differential diagnosis among postmenopausal pathology responsible for abnormal uterine bleeding, both directly and through the possibility of target endometrial sampling. Of course, this is a failure of office hysteroscopy because of fibrotic cervix. Then you see there 26 failure versus 7 failure when it is not menopausal. So in this case, many authors will prefer to use cervical dilatation. If we recommend the routine administration of mifepristone or misoprostol to women before outpatient. Even you have a cervical stenosis like this, you have to manage it with a grasp. You don't cut anything. You have to dissect and to try to find the way to enter inside the uterus, and the bubble is entering, so you know where is the way. At this moment, you can cut and enlarge the cervix to enter inside the cavity and to treat pathologies if needed. And the misoprostol, when you use the misoprostol, with this publication advised to use the misoprostol 12 hours before, not 3 hours before. It seems to be better in relieving pain. Just to show you the cancer, this is a picture of cancer. This is a polyp. Don't let the endometrium and to focus in the polyp. There is a cancer. When you have this, you have to stop the procedure. How about the neoplastic dissemination? Many recent publications say that the neoplastic dissemination is very moderate when the pressure, when you work with the pressure less than 80 millimeter, when you use less liquid, and especially when the stage 1 or 2 of the patient. This is the first systematic review and meta-analysis to evaluate the safety of hysteroscopy in early stage endometrial cancer. The results indicate that hysteroscopy is not associated with worse prognosis in patients with early stage cancer. So hysteroscopy is safe. We don't have to avoid it if we suspect a cancer. We have to summarize for cancer in office hysteroscopy. Hysteroscopy grasp biopsy is more accurate to diagnosis than tape and the grad compared to Blind Novak said this piezo, there is no association between preoperative and war perniosis. And also the Mercenaire was studied. Hysteroscopy with morcellation is a safe method to diagnose. It does not lead to increased dissemination of malignant cells. What about the indication of office operative hysteroscopy? All these pathology, polyp, myoma, synechia, septum, retained product of conception, IUD removal, and it is cheaper. But it depends of the size, of the duration, it depends of the instrumentation you use. Of course, it depends on the skill of the hysteroscopic and the compliance of the patient. We have to discuss with the patient before, during, and after the surgery. We have to know the limit of hysteroscopy. We cannot diagnose the adenomyosis even we this PSU advise us to go more than endometrium and to do the biopsy with spirotom. The myomaterial, the residual myomaterial thickness, we cannot have the measure if we don't have a good and accurate ultrasound. We cannot be the difference between the septum and the bicornuate uterus. We have to do ultrasound. Many moderate complications are described, but it is less than 1% of a procedure, and in office hysteroscopy there is less complication because the patient is awake and they cannot allow you to perform the uterus. This is a false way, this is a wrong way, this is the cavity, and after we have the wrong way. But we can finish the procedure when we have a good way. But when we have perforation, you have to stop the procedure. But it is not a dramatic situation. We have to stop, especially when you do the perforation with mechanical instrument. So you can keep calm and you can precise the diagnostic. You can at least exclude the cancer, and you can perform later, 2 months later, the procedure in hysteroscopy. I will show you the synechia. This is fibrotic synechia. There is other adhesion in the fundus. So with mechanical, we prefer using mechanical, especially when there is synechia. As you see, there is no bleeding. Even use mechanical instrument, we don't need energy, and we have to treat all the synechia at the same time. The outcomes after treating the synechia is better when you treat all the synechia at the same time, and the result is excellent at the end of the surgery. This is another synechia with IUD inside. This is the synechia surrounding the endometrium. So we can cut the synechia with scissors, as you see, without removing the IUD. You can let the IUD inside and you can replace it if it is misplaced, like this case. Another movie, this is a polyp blocked the fallopian tube. You can use the hysteroscope to remove this polyp, which was inside the tube, which blocked the tube, and the patient became pregnant after hysteroscopic surgery. Well, even the polyp inside the cervix, there is no evidence that it impairs the fertility, but when you go to the transfer, they can impair the transfer, and we can treat the polyp, the large polyp, with using, I prefer to show you this movie. It is fibrotic. We cut the slicing, we cut the polyp in 2, 3, 4 portion, and after we don't have a problem, we don't have an issue to extract the polyp. If you you put it longer, we can have a problem with its extraction. And this is a blue cyst inside in the endometrium. It is, we can remove the adenomyosis. We can use this instrument spirotom, but we can use the scissors like this. I don't have the spirotom, so I do it. I cut the endometrium, I find the cyst, and after I use the scissor to cut and to remove this part. There is no evidence that they improve live birth, they improve the fertility, but we can increase the diagnosis of adenomyosis, and studies are needed to confirm that there is outcome for fertility. This is calcified osteoid metaplasia. Yes, it is very big. It is strong. We can do the injury if you remove it. So we cut it. We divide it in 2, 3 pairs, and we remove it at the end. To success the of hysteroscopy, we don't need for fasting. We need for calm environment. We need to support the patient with vocal anesthesia and consent. We have to use the traumatic insertion technique, respecting the endocervix, respecting the myometrium, respecting the indication. We have to do a perfect and the correct indication, and we have to manage of removal tissue shapes. Well, that's why I prefer a shaver, because we don't have to manage of removal tissue service. As a specialist of IRT, do many techniques to improve the base blastocyst. As you know, the cavity is not the main in all the patients. There is many cavities. So in hysteroscopy with this instrument, we can improve and we can give the best cavity for the best embryo. Thank you very much for your attention. You are in mute, Mohammed.
Dr. Farghali, you are on mute. Unmute yourself, please.
Thank you, Dr. Faid, and thank you sincerely for this inspiring amount of time and the effort you spent to do this video. We are all impressed by these videos.
Thank you very much. Thank you very much.
My first question, did you have any published data about your cases and the use of office hysteroscopy as operative technique?
Have
published data.
My published data?
Yes.
No, my published data, unfortunately, I don't publish it, but I will do it in the future. Because in Algeria we have not law to permit using electrically inside the office, and I would like to do the office without, because the new statement of the different procedure, we have to respect the office. Office have to do, you have to perform the hysteroscopy inside your office, not in the hospital.
Yes. What about the counseling of the patient and acceptance of the patient to do operatively without anesthesia?
Good question. It depends of the symptom. If the patient come for the abnormal uterine bleeding, I think the acceptance is easier and is frequent. But it's a problem in our region because the woman, the status is the woman is not the same, and she wants to show that will be an operation, a big operation in the operative room. So I have many issue with the acceptance for the infertile women.
Yes. As you know, in our region, many women to put an ICD need anesthesia. Not
Yeah.
movement.
I think they need a counseling. They need the spread of this technique. I think vaginoscopy is very important. We have Academy of Hysteroscopy. In this academy, we learn a lot how to make office vaginoscopy, because vaginoscopy is a method which reduce significantly the pain when using this technique.
This is my next question. What is about the learning curve? How many operative hysteroscopy you need to do this?
But I think we have to do at first the diagnosis. I think 30 patients, if you perform 30 patients in diagnosis, we can increase your level. We can do to the small polyp. After small polyp, you can cut one small adhesion, one small synechia, and after you can go to treat major intrauterine pathology. For example, for my part, I don't perform energy in office. I do it in the clinic, in the hospital without anesthesia. But I don't. There is no law to permit me to do it in the office.
Yes. Did you advise a general gynecologist to do operative office hysteroscopy?
Yes, of course. I think.
You know that you are an expert in hysteroscopy, but as a general gynecologist, did you advise him to do this?
Yes, of course. I think when you perform 13 hysteroscopy in the clinic, after you can go to the office hysteroscopy, and you can add the medication. You can use the office with opioid, for analgesic, for anti-inflammatory. We can use little medication for this. I think we have to spread. Another argument is the shaver. I think the shaver will be a revelation in this field because it doesn't need any expertise. You can do the shaver, and the shaver they reduce it. The last one is 5 millimeter, the outer sheet. So I think with this development, we will perform this technique easily in the future.
An element of time. If you decrease the time, you can do it.
Yes, sure.
Thank you, Dr. Faid, and nice to see you and see your videos today. And thank you, everyone. And at last session, we want to thank Organon for organizing this scientific event. Thank you, Fatma. Thank you, Walid. And thank you for the technical support team. Thank you, everyone.
Very much. Thank you. Bye-bye.
Exactly.
Bye-bye.
Thank you. Thank you. Bye. Thank you, Dr. Farghali. And as we say, every beginning has an end, and every end is a new beginning. But at the end of today's program with the contraception, so thank you for our dear speakers for accepting sharing with us contraception. Thank you for our dear attendees for you honored us with your and hope to see you tomorrow for the fertility program. So thank you. Have a wonderful rest of the day.
Yeah, thank you.
Thank you.
Bye.